Well, good morning, everybody. Welcome to Faculty Development Summer Series. Today is our last in the Summer Series sessions. Just a brief announcement. Next week, there is no Grand Rounds or Summer Series, followed by the Wednesday after that, which is September 4th, is our very first Grand Rounds. That's Dr. White's State of the Department address. So that is September 4th back in Donny Auditorium. For those of you online, if you want to join us in person, we are up in the 5th floor cardiology conference room right now. Donny Auditorium has been usurped from us. So we are up in the cardiology conference room. There's breakfast. Feel free to come on and join us up here. For our last session this morning, we have Dr. Josh Arthur. Dr. Arthur is Associate Professor of Pediatrics and Healthcare Ethics in the Division of General and Academic Pediatrics. Dr. Arthur is going to talk about the impact of social determinants of health on pediatric healthcare. Josh.
Thank you. Yes, if you want to come up at the cardiology conference room, there's a plate full of donuts and 3 people, so it'll make it a little easier for me to talk too. But thank you for your attention. So yes, my primary job is general peds. But one of the key roles that I also play at the School of Medicine is that I teach a course called Medicine and Society that helps M1s and M2s explore the way that social factors impact the clinical setting. The things that happen outside of the hospital have a big impact on the health of kids inside the hospital. And so this talk today is drawn from some of the content that I give to them. I don't have anything to disclose today. So the agenda today is going to be, I'm going to first talk about this concept of social determinants of health, give you some definitions. And then I'm going to sort of drill down on specifically into the concept of poverty and how it impacts children and families. And then I'm going to sort of shift gears to talk about what we can do about it as physicians and healthcare professionals. So I'm going to start with the story. This isn't like one individual kid. This patient, John, is sort of a constellation. And if you work in urgent care or you work in primary care or pulmonology or probably anywhere in the hospital, you've seen kids sort of like John, and so you might recognize some features of this story. He's a 5-year-old male with persistent asthma, allergic rhinitis, recurrent ear infections, speech delay, obesity. For the sake of this example, you're just meeting him today and you go through his record and you discover he's been to the ED 15 times. He has 5 hospitalizations, including 1 in the PICU. For poorly controlled persistent asthma. His family's missed multiple pulmonary and PCP appointments in the past year. So what I'm going to provide for you now is sort of 2 responses that you might have, that you might reasonably have when you first meet this family. And I'm going to suggest to you that one of these responses might be better, and then we'll talk about sort of how you all could incorporate that type of response in your practice. So response number 1. A review of his records demonstrates frequent missed follow-ups and refills. He is not only at risk for significant illness from lack of medication access, but also environmental smoke exposure is an ongoing trigger for deterioration. When you speak about the importance of daily inhaled steroid medication and smoking cessation, mom states her discomfort with steroid use for her young child. Moreover, she seems pre-contemplative regarding quitting smoking. He uses his inhaled steroid and albuterol only when he's sick, but the medications cannot be found since home repairs began last month. And after prescribing new steroid and albuterol, mom requests a note for school. He's missed the last couple of weeks due to his asthma. And so you're frustrated by the familial reluctance to initiate appropriate care, and you exit the room saying sort of passive aggressively, he won't get better without your help. Clearly, John's parents are not prioritizing his health. So that's response number 1. Response number 2, so you start by asking the parents what triggers they identify for John's asthma, and the parents note several factors, including smoke exposure, mold in the house, and that they lost medications during home repairs for the mold. Mom seems pre-contemplative regarding quitting smoking, but on further questions, she reveals that she stops smoking cold turkey after his last admission, but restarted after a week. So this time, she accepts nicotine replacement and smoking cessation support. She discloses financial stress with unemployment, a car accident, and a recent move to a shared house with a maternal grandmother, which is stressful. Staff within your clinic mobilized to assist the family in follow-up after the visit. They engaged the St. Louis Asthma and Allergy Foundation of America to provide the family with asthma mitigation tools for the home. John's physician has been building an ongoing relationship between the clinic and the Asthma Foundation to strengthen the clinic's services to kids just like John. So the differences in these responses, I mean, they're kind of obvious, but I want to draw attention to what makes these two responses different. So the first one, and entirely realistic, given my experience sort of in clinical encounters like this, the first response sort of identifies that there are barriers to this kid's health that aren't really medical. But what it does is it sort of localizes these barriers at the level of the parents. It says, parents, why aren't you getting refills? Parent, why aren't you coming for appointments? Parents, why don't you quit smoking? And the issue is that unless there's egregious abuse or neglect, these parents are going to continue to be as parents, meaning that the barriers aren't going anywhere, and that's going to make change difficult. Response number two also identifies the social factors as barriers, but then it seeks to go to the next level, and rather than seeing the parents as barriers, sees parents as teammates, or works to create a therapeutic alliance, identifying the fact that the parent and the clinician both want the kid to be healthy, and then asking the types of open-ended questions that allow you as a clinician to then clarify what are the barriers that obstruct the parents from helping the child achieve the health that they want for the child. So it uses open-ended questions, learns about the multiple layers of barriers that emerge from poverty. And because now in that second response, you actually identify some actual barriers, it provides an opportunity for achievable change. Perhaps now the parent and the clinician can come up with some targeted interventions that can make this kid better. The goal of today's session is to help you learn a little bit more about the social barriers that impact health, so that you can be the type, and I can be the type of clinician that can dig a little bit deeper and understand the barriers a little bit more within the sort of, rushed clinical encounters that, we have every day. So what are these things that are interfering with the health of our patient, John, from the case? These are the things we call social determinants of health. My first slide, I'm going to give you a little bit of the sort of theoretical underpinning for why these are important. Some of you may have seen this pie chart before. This is from the New England Journal of Medicine a few years ago. And what it does is it demonstrates the proportional contribution to mortality, or premature death. And I think you can probably extrapolate it to morbidity as well. And so if you look at it, it shows that when you think about people dying earlier than they need to, certainly genetics play a large role. You also can see healthcare on there as well, playing an important role, although for some of you, since we're in healthcare, you might think that's a little bit of a smaller percentage than you might have imagined. And then you see the rest of the categories are what I would call sort of the social behavioral factors. So environmental exposure, this is exposure to like lead toxicity or excessive heat in your neighborhood or air pollution. Social circumstances, this would be things like access to healthy food, quality education, a safe and nurturing home environment. Down at the bottom, you see behavioral patterns. And you might think to yourself, well, behavioral patterns, those aren't social. That's just what you choose to do. Like you choose to smoke or you choose to eat unhealthy food. And while at some level that's true, at another level, one thing we know about behaviors is that they're driven in many ways by the cultural milieu in which people live. If you think about things like tobacco use, part of the reason that it's dropped off precipitously over the past 50 years is because you don't see advertising for tobacco use in sporting events or on TV, and it's actually a lot more expensive to smoke than it used to be due to taxation policy. In other words, the types of health risk-taking behaviors that people participate in are driven very much by the policies and the social setting in which they live. And if that's true, then that underpins my first statement here, that over half of premature mortality is driven by the life circumstances in which people live. And if we are people that are interested in decreasing morbidity and mortality, then it becomes very interesting to us to understand those circumstances and what sort of interventions that we can make. So that underpins the sort of emphasis on this idea of social determinants of health. And I put on here the World Health Organization's definition of social determinants of health, the conditions or circumstances in which people are born, grow up, and age that affect their overall health, health risks, and quality of life. And so in the ensuing slides, we're going to talk about some of those social factors. I mean, there's probably hundreds of social factors that influence health, but there's a few that probably get the most attention because they have this sort of the lion's share of the impact on health outcomes. This particular slide is from Robert Wood Johnson Foundation, and it looks at just some of the social factors that impact the health of kids. On the y-axis here, you see sort of a Robert Wood Johnson metric of percent of kids that are in less than very good health. So you don't want to have a high number of kids in less than very good health, so the higher bars are worse. Along the y-axis, you see different sort of social factors that impact health. On the left, you see household income, and you see very clearly that those in the darker green, lower income households have considerably higher percentage of kids that are in less than very good health. Likewise, the middle is household education. If you live in a household where the caregiver has a low educational attainment, you're much more likely to be in less than very good health. And then on the right, you see racial and ethnic groups, and you can see, so from left to right, it's Black, Hispanic, and white. You can see that there is a considerable difference between racial and ethnic groups in likelihood of being in poor health or less than very good health. And of course, for any one kid, they're going to have a constellation of different social factors, and certain kids are going to have a constellation of the most high risk social factors, which lead to disproportionate impact of certain social factors on certain populations. And these aren't subtle differences. You can see these are 3- or 4-fold differences in the likelihood of good health just across different social groups. And if the differences are this profound, it's important to understand why. If you've worked in St. Louis at all, or really any urban area, or really in clinical medicine at all, you'll quickly recognize that these types of social factors are not evenly distributed across a geographical region or across society at all. If you're interested in things like heat maps of population level health data, you can use Policy Map, which is available in the SLU Medical Library. Here's just one heat map of an indicator called the Child Opportunity Index. It looks at things like the quality of education systems and healthcare access and healthy food and places to play for kids that live in our region. The smiley face in the center is where you're sitting right now. Well, I guess if you're at home, you could be anywhere in the region, but where I'm sitting right now is right in the center. And you can see to my north, south, and east, there are considerably lower levels, the lighter color, of child opportunity, whereas to the west, you can see a considerably higher level of the types of social factors that benefit health outcomes. And so if you look at a map like I just showed you of the different ways that child benefiting health factors are distributed around our region, the thing that makes this map different are all the things that I would call upstream factors. And so this next diagram, some of you have seen before, but I think it's important to understand the idea of upstream, downstream factors. So I'm going to take a little sidebar here to sort of tell you what I mean by upstream and downstream. So some of you may have heard this story. So the idea of the upstream, downstream map or sort of example is that if you can imagine that you are sitting by the river having a picnic, sitting by a stream, I guess I should say. And as you're sitting there, you hear somebody yelling and splashing in the water. And so you run to the side of the water and you pull them out. You go back to your picnic. A few moments later, somebody else is yelling and screaming and splashing. You go over, you pull them out too. A few minutes later, somebody else yelling, splashing, you pull them out as well. And you start to wonder, why are so many people sort of floating down this river? And you walk a little ways upstream and you realize that there's a bridge there and the bridge is broken. And people are just, walking down the street, looking at their phones, falling in the river. And so at that point, you have the opportunity to make some sort of health intervention. You could do sort of a quick educational intervention, put up a sign, say, bridge is out, don't fall in. A few people probably would read it, and a few people would probably still fall in. You could do sort of what I would call like a structural intervention. You could loop in local stakeholders, construction companies, funders, community members actually fix that bridge. But that'll probably take a little more time, a little bit more investment. Or you could just go back downstream and keep pulling people out of the river, and they would probably really appreciate it. The point is, all of these solutions are valid solutions. They depend on sort of how much time you have, what resources you have at your disposal, and just sort of what you choose to do. So take this example and apply it to the clinical spaces that we work in every day. We spend a lot of our time downstream. We spend our time taking care of kids that come in with chronic illness, with the outcomes of poor maternal and child health, with allergic and infectious disease. Why do I list these several things that we see in clinic? It's because of these particular health outcomes are described in the American Academy of Pediatrics policy statement as outcomes of living in a household with poverty. So we see the consequences of kids living in households with poverty every day, and we're a children's hospital, and we should be really good at identifying and intervening on these needs. But my goal for all of us is through this talk and just through in our clinical spaces is that when we're doing this excellent work every day is to also have a second lens where we're always looking upstream. We say, but why are kids coming to me like this? Why am I seeing so many kids splashing and yelling in the river that I'm pulling out? And the goal is for you to be able to look upstream a little too and say, you know, the reason that kids are coming in with this chronic disease that's undertreated is because of issues with income, issues with education, issues with housing. And then think to yourself, can I be a voice? Is there a way that I can be maybe a part of fixing that bridge? And we'll talk about that as we go through this session today. I'm going to concentrate on one particular upstream factor because I think it's the one that's probably in some ways the most prominent in the day-to-day work that we do at Cardinal Glennon. I'm going to talk about poverty specifically because a lot of things like housing, transportation that are issues for our families sort of stem out of poverty. At the Donny Pediatric Center where I work, over 80% of our patients are low-income patients on Medicaid, meaning there's somewhere between 150 to 180% of the federal poverty line, their family's income, or somewhere below that. At Cardinal Glennon, this about 50% of our patients, last I looked a couple of years ago, somebody on this call may know more than I do, but it's about half of our patients that are on Medicaid. And this is disproportionate relative to the society. And so I want you to sort of think about that. Why would a hospital see so many more low-income patients than the general society? And certainly the sort of market share and geographical reasons for that are above my pay grade. But I also want to suggest that poverty itself makes people sick, and being sick perpetuates poverty. Here's a chart to sort of support what I just said about this vicious cycle. And this is a chart of adults because I give this talk to med students, but I think it applies to kids as well. If you look along the x-axis, you will see household income percentile. Along the y-axis, you see basically life expectancy. And what you can see is essentially a linear relationship between household income percentile that goes all the way to the very top, all the way to people making millions of dollars a year. You might ask yourself, well, why is there a linear relationship between household income percentile and expected age of death? Is it because people who have more money have the ability to access health promoting things like healthy food and places to exercise and so forth? Or is it because so does just being rich allow you to access health? Or does being healthy allow you to engage in employment and financial resources if you're healthy, so that health helps you be more affluent? And I would say the answer is yes. The answer is both. It is a vicious cycle, and that's why you see at the very sort of tail end for the poorest people and the poorest families, you see a real steep drop off for those who really just don't have adequate resources of neither health nor of affluence. And that explains why hospitals like ours, like SLU Hospital and like probably many hospitals in the region, you're going to see a disproportionate number of people that are impacted by the challenges of poverty. So I'm going to spend a few slides on numbers because I think this is really interesting in understanding the way our society works. And then maybe we'll help you understand sort of what you see. So how do we define poverty specifically, like the actual nuts and bolts? So every year, the Department of Health and Human Services sets a certain number that they call the federal poverty level based on what they believe that the average family at subsistence, meaning the average family that's just getting by, they're not like flying and doing great, but they're surviving, how much money they would need to make in any given year. And so then they say, okay, if that's the subsistence level, then people below that aren't subsisting, so they should be eligible for various government programs. And I'll list a few of those out in a moment. And so the federal poverty levels used to determine what people get, things like Medicaid and other things. So how do they decide on that dollar value? Well, the federal poverty line equation was proposed by an economist named Molly Orshansky back in the 1960s. And what she did was she looked at families that are at subsistence. They're getting by and they're surviving, but they don't necessarily have excess money. And she noticed that those families spent about a third of their money on food. So she said, well, let's just do this. Let's go to the grocery store, fill up a cart with a month's worth of food, multiply whatever that costs, multiply that by 3. That is the federal poverty line. So that continues to be the equation for the federal poverty line today. I want you to think about whether the buying patterns in the 1960s still fit sort of the cost of food and the buying patterns today. Just sort of cogitate on that during my next couple slides. So what the equation comes out to this year is that if you live anywhere in the United States, the continental United States, the federal poverty line for a family of 4 is if you make less than $31,200. Many of you are probably thinking that's a pretty low number, and it is, and I'll tell you why and sort of what that would buy you in the next few slides. So I'm going to now go back to that equation that I was saying. Do you think that really fits today or not? It doesn't. So one of the things that is different about our economy today is that relative to the price of everything else, food has become less expensive than it was in the 1960s. Now, this may be a little dated over the past couple of years because food seems really expensive, but on average, the family at subsistence level now doesn't spend a third of their money on food. They spend about a seventh of their money on food because they spend everything else on things like transportation, childcare, medical expenses, and housing, things that got more expensive. But the equation still is what it is. It's still, the federal poverty line is defined as 3 times what it costs to buy that cart of food, which means that if you're at the federal poverty line, that means you're making 3 times more than what it costs to buy food, but then you don't have enough money to buy all of the rest of the things it costs to raise a family because the rest of those things became more expensive. This is a graph here, not of just people at the poverty line, but just of all population. And you can see how the relative price of food has decreased by about 50% for everybody over the past several decades. And then the other thing to just notice about the federal poverty line is that the amount you can buy for $31,200 in St. Louis is probably different than rural Missouri. It's very different than San Francisco or New York, and it's the same poverty line everywhere. So noting that over time, because of this sort of drifting away of the federal poverty definition from sort of reality, over time, what that means is that people at the poverty line are becoming relatively actually poorer, or meaning more resource deficient than they were in the past. And I haven't been alive since 1963, but for people who have, you may have actually noticed sort of in healthcare, sort of trends in what the resources are of people at the federal poverty line. And sort of noting this, different economists over the years have advocated for changing that definition. This is a quote, but it requires an act of Congress. It's hard to get, which is why that hasn't happened. This is a quote from Dr. Rebecca Blank. She was the Secretary of Commerce back in 2008, and this was from a talk where she was advocating for changing how we define poverty. And she was making the point that poverty isn't just about food, even though the equation is linked only to food. She says, in the United States, financial security means more than merely escaping starvation. It means being able to purchase the goods and services that are necessary to afford adequate and stable housing, find and hold a job if physically able, participate as a citizen in the community, keep oneself and one's family reasonably healthy, and provide the things that one's children need to participate effectively in school. So this is what we want, I think, for all of our patients and really all of our community members. But what does it cost to reach that level of financial security that Dr. Blank is suggesting? So there's lots of calculators online, and if you're at home, you can, on a different screen, you can like pull this up for your hometown or here in St. Louis. And then you can look at sort of what the cost of living is. Remember, the federal poverty line this year is $31,200. The median household income, this last available from the census data, is $74,580, which is a little over twice the federal poverty line. I just pulled this number sort of a few days ago from a sort of a local public health organization that has a calculator of the monthly cost for a family of 4 in the St. Louis area that's essentially just getting by, don't have a lot of excess money, but they're surviving. And I do this every year for my talk for med students. This is the first time that number has been in 6 figures. So this year, they say for a family of 4, it would cost $100,000 to live in the St. Louis metro area. So compare that to the federal poverty line, like over 300% of the federal poverty line, and compare that also to the median household income. That means the average family is actually going to struggle to make ends meet if they're living in the St. Louis region. Probably explains what you sometimes see in your clinical spaces. How many people does this impact? These numbers have changed a little bit, but they're about right. So 60% of families are 200% or more above the federal poverty line. 22% are what we call low income, 1 to 2 times the federal poverty line. Many of those would be eligible for Medicaid, so you may see them on Medicaid in your clinic. 19% are below the federal poverty line, and of those, about half of them are below 50% of the federal poverty line. So essentially 1 in 5 kids live in a household that's below the federal poverty line in the United States. How is this distributed across the country? There is poverty everywhere, but you can see areas of concentration, sort of the Appalachian areas. You can see in the Southeast areas, sort of indigenous or Native American reservations also tend to be areas of concentrated poverty as well. So this next, this video is going to look at sort of what are the practical implications for the day-to-day life of a family living in poverty. Now this video is, I think, 5 years old, so the federal poverty line was a different number at that point, so the numbers are not quite precise, but I think the principles make sense. This is about 3 minutes, and then we'll move to the next slide.
Right now in America, more than 46 million people are living in poverty. That's the largest number in more than 50 years, more than the combined populations of all these states. Who lives in poverty, USA? Nearly 1 out of 6 Americans. Wage earners who've lost their jobs, seniors who can't afford their medicine, people in the military, families living on minimum wage, and worse yet, 1 in 5 children. What's it like living at the poverty line? How do you make ends meet? According to the U.S. government, a family of 4 is living in poverty USA if they're making less than $22,811 a year. That's $1,900 a month. Just how far will that take you? Not very far. Take housing. At the poverty line, you'll pay about $565 a month for basic shelter. How about keeping the lights on and the kids warm? Utilities, $250 a month. You'll need to get to work, to childcare, to the store. But public transportation isn't always available. A used car, gas, and maintenance runs about $345 a month. What about food? You'll average about $356 a month, or you'll go without. That's why hunger can be a problem when you're living at the poverty line. But maybe you can qualify for assistance, like food stamps, or subsidized school lunches. And while you're at work, your younger children will need childcare. Even with subsidies, you'll spend $220 a month. Now, healthcare. Even with government assistance programs, it will cost you, on average, $220 a month for insurance, out-of-pocket expenses, copays, and prescriptions. Of course, a surprise illness can be devastating. Many low-wage jobs don't provide sick leave. If you miss work or stay at home with the kids, you'll lose those days' wages, or worse, your job. Now it's the end of the month, and you've run out of money. But the expenses keep coming. Clothing and shoes for your growing children, school supplies, never mind saving for college. What will you let go? Can you hang on until the next payday? Or will you fall deeper into poverty?
So that depressing video sort of gets at the sort of just practical external ways that poverty is going to impact the health and well-being of your patients. I'm going to take that sort of concept and I want to package it with sort of an understanding that poverty doesn't work just only at the macro level. It also works at the sort of micro and cellular level. Actually, I'm going to suggest to you that there are various ways that various pathophysiologic mechanisms of the way that poverty may perpetuate the poor health of your patients. I'm going to talk just briefly around toxic stress, epigenetics, and environmental toxins. I'm going to do it briefly because I don't want to embarrass myself talking about endocrinology and genetics, but I want you to just have some basic concepts that you can look into more if you're interested. So, toxic stress. So many of us are familiar with that concept. It's the type of stress, not the sort of intermittent stress of like giving a faculty development lecture, but like the constant stress that families experience or that kids experience living in a household with poverty. The sort of like wondering where your next meal is going to come from, wondering like where you're going to sleep tonight, just sort of the transferred stress of your parents always just trying to make it work. When that happens and kids are chronically exposed to stress, they're chronically stimulating their hypothalamic pituitary adrenal axis, constantly secreting higher levels of cortisol and cytokines. And we know that those types of endocrinopathies actually change the way that the brain develops. Kids have lower brain volume, they have a worsened executive functioning and developmental delay, like our friend John. Also, just that sort of a milieu of increased cytokine activation means that John's going to constantly have pro-inflammatory physiology. What does that mean? It may mean that he's coming into the hospital more often with his asthma exacerbations. Epigenetics, you're familiar with sort of the idea that sort of environmental factors, both in utero and early in life, can actually cause methylation of the DNA that drives the way that the genome is expressed either for years or throughout the whole life. We know for somebody like John, in utero exposure to things like tobacco exposure and air pollution increased the risk of him actually having worse asthma for the rest of his life. Things like fetal alcohol syndrome and gestational diabetes also precipitate the types of epigenetic changes that can result in long-term health outcomes for people like John, and those particular epigenetic changes he's at more risk of those types of changes because he lives in a household that experiences poverty. Environmental disparities. So this is a graph here of lifetime cancer risk. This graph is from Southern California, and you can see on the x-axis that the lower someone's household income, the higher likelihood that they are going to have cancer as they get older due to exposure to airborne carcinogens. What this means for somebody like John who lives in a low income area, it means that he is more likely to be constantly breathing in airborne toxins, again, precipitating the types of medical issues that you see for him. So if you put all of this together, the video you saw with the sort of practical implications of health barriers that arise from poverty, things that are happening at the cellular level at different doses. How much stress is he getting? How much environmental toxins is he exposed to? What is his genome doing as a result of exposures that his mom and his family have? What you end up with is kids like John seeing a disproportionate number of an accumulative effect of different doses of things that negatively impact their health. I showed you a heat map showing how these types of factors aren't evenly distributed. Likewise, the health of a kid like John, his likelihood of asthma exacerbations is also not going to be evenly distributed. This is how we see, this is what health disparities are. It's putting everything together in our society, in the individual body, and resulting in a kid that is going to be predisposed to be less healthy. So that is where I'm going to make the shift from the depressing part of my lecture to the what can we do about it and some maybe positive things. I wanted to really sort of pound in your minds, I think I did, that these things really make a difference. They're big problems, and in an invisible way, they're impacting every single patient that walks into your door, whether in a positive or a negative way. But there are some good things to say. This is a story from the New York Times, I think now a couple of years ago. And it's called Expanded Safety Net Drives Sharp Drop in Child Poverty. It's like a long form story with some like patient stories in it. It's really good. And what they point out is that actually from 1993 to 2019, the number of kids living below the federal poverty line decreased by 59%. They did not include 2020 and 21 because COVID relief programs like created a weird inflection point that wasn't sustainable. But if you do include 2020 and 2021, the drop in child poverty was actually more like 70 to 71%. So you can see that on this graph. And this is a good story. This means that people like you and me, healthcare professionals, business people, parents, teachers, legislators looked at child poverty and said, this isn't acceptable. This something needs to change. As a result, we now have sort of a patchwork of state and federal programs that act as what we call it's truly a net, sort of a network of programs that, while the problem with a patchwork is that it can be confusing to access for families, on the other hand, the good thing about a patchwork is that it's hard to undo even if people try. That's sort of the positive spin on it. And if you look at this story here on this slide of the drop in child poverty, there's something here for everyone. If you're sort of a classic conservative and you say, the way to decrease poverty is pro-business policies that increase employment and increase workforce participation, you would be right. This big drop here in the 1990s was a time of economic growth. It was a time that many single moms, especially, returned to the workforce, pulling their families out of poverty. And it made a big difference. If you're a classic liberal and you say, no, it's, government programs that are going to help keep kids and families out of poverty, you would also be right. So if you look, you can barely see it on the slide, but you see in the 1990s, 2000s, you see two recessions as sort of like a little bit darker gray areas, including the Great Recession in 2008 to 2012. And what you see there is you don't actually see an uptick in poverty. If anything, during that Great Recession, poverty went down. And that is a testimony to the types of programs that exist to keep kids from falling into poverty. They both work. And so this is a good story. It's not a great story because there's still millions of kids in poverty. We see them every day. And part of the goal of this lecture is to make us a part of sort of the next chapter. What can we do to continue this positive trend? As I suggested to you, there is data to show that public benefit programs make a difference. If we didn't have government programs, the number of kids in poverty would be, instead of 1 in 5, it would be more like 1 in 3. It's useful in your day-to-day clinical work to be aware of some of the programs that exist for kids like John, and that use a federal poverty line for eligibility. I put in red some of the ones that I think would help our big patient from today. You're probably all familiar with the supplemental nutrition programs, WIC, SNAP. Head Start would be an early childhood program education program he could participate in. Medicaid certainly is going to be relevant for him. And then there's all these programs, some you may not know about. Weatherization assistance, if heat or cold triggers his asthma, he can get help in his house for that. Legal services, if he needs help sort of pushing his landlord to make his house livable. Each one of us, on this call or in this lecture, have different patients with different needs, and it's useful to have a little bit of familiarity with what specific things exist for your particular patients, because the things that they need might not always be the same. So you may be thinking to yourself, I agree with you, Josh, this is really important, and I want to do something about it. What do I do? The answer is you can do all sorts of different things, because each one of us is going to have a different approach. Like personally for me, people who know me well know I don't like going to Jefferson City. I don't like conflict. I don't like talking to strangers. That's just not going to be my style. I'm going to like to do grassroots types of community projects. And so that's what I do. A few years ago, Academic Pediatrics put together an issue of child poverty interventions in the United States. And what you'll see if you look at the titles is there's all sorts of things you can do. Some people are doing things like reforming the education system. Some people are working on home visiting programs. Some people are working on health insurance and taxation policy. Some people are looking at learners and medical students. Some people are looking at improving the clinical space. All of these are valid. All of these are relevant. And so as you think for yourself, how do I fit into these solutions? Look at issues like this and others that may give you some suggestions about what might fit for you. In the day-to-day work, there's little things you can do. So in that everyday clinical space, this is the top half of the screening questionnaire we use in the Donny Pediatric Center. If you come in for a checkup, we're going to give you sort of a constellation of standardized, validated screening questions, but also some just homegrown questions that address the needs we know our patients have. And then we have trained staff and medical students that will then connect families to community resources. And so this is sort of our downstream intervention. By the time the patient gets to me, they're already impacted by all of these social factors, but it's a way that we can try to address them sort of promptly and in the clinical space. And if you're interested, I know there's other programs, Unite Us and the hospital, that are doing similar work. Certainly feel free to talk to me or Jean Labarge if you're interested in knowing a little more of what we do. But I would suggest to you that we can also, besides doing great work in the clinical space and thinking broadly and holistically about social needs, we can also think bigger. We can think we are, as a hospital, as a faculty group, we are a network of people, and this definition, and we can be advocates. This is the definition of advocacy from the American Academy of Pediatrics Advocacy Guide. They define advocacy as speaking out on your patient's behalf, or I might say like amplifying your patient's voices. Advocacy assumes that there's a problem that needs to be changed. I've made that argument, and there's a way, and it's a way to drive or affect that change. Advocacy allows you to move from treating one patient at a time to being part of a broader network of advocates that works systematically. So this broader network of advocates, that means us, we can identify maybe flaws in the system, bridges that are broken, and be the voice that calls for a solution. So what is uniquely powerful about our voices? Why should we be the people speaking on behalf or amplifying the voices of our patients? Well, the Missouri Foundation for Health a few years ago did focus groups and asked people across Missouri who were the most effective messengers for health issues. And I'm happy to say at the top of the list, it was basically teachers and doctors. Bottom of the list, not to badmouth anyone, but it was like public officials and media and legislators. In other words, we are people with professional credibility in different populations. And why is that? Partially it's because, at least in our best moments, we can speak dispassionately, not without bias. We focus on the data and the evidence, and we communicate it in a way that people can understand. And so that's one thing, we have good data. But I think the second piece is also we have access, especially for kids under the age of 5. We may be the only people that see some of our most vulnerable kids who aren't yet in school. We have consistent contact with patients and families that society maybe just doesn't see. and we are a witness to the struggles of our patients, which gives us the opportunity to amplify their voices in a way that they may not have the platform to do so. So what can this look like? I'm going to suggest to you, you may not believe it, but you have power. What do I mean by the word power? In this context, I'm not meaning tyrannical power. I don't know if any of us that have that, but I'm using it neutrally to just say, we have the ability to act. We have the tools and the ability to act and maybe even change some things. So then the question for you all is, how can you leverage your specialized set of skills, the relationships that you have across the community, and the social capital you have, people trust you, to affect change at the individual, community, or population level? Ask yourself that question. How can you use the platform that you have? Here are some examples that I can give you of different pediatricians doing cool stuff. Up on the left, this is an op-ed by Colleen Kraft. You may remember her. She was the former president of the American Academy of Pediatrics. A few years ago, she went to the US-Mexico border and visited a bunch of the migrant detention centers to draw attention to what she believed to be inhumane treatment of children. She wrote an op-ed in the LA Times because that's where she practices, and then did the sort of morning news circuit and was a voice for her patients, which as the AAP president were all the patients that were in our country. The second pediatrician is Dr. Roy Guerrero. He is a pediatrician in Uvalde, Texas. He was a pediatrician for many of the patients at Robb Elementary, the site of a mass shooting. He is testifying in Congress about the way that firearm violence impacted the patients that he serves. And then on the right, I don't know who all is watching virtually. Some of you may be in this picture, but this is the Missouri chapter of the American Academy of Pediatrics. Every April, we go down to Jefferson City to advocate for kids, things like safe sleep or vaccination or car seats. And if any one of you are interested in coming along, let me know. It always happens in April. I don't know the specific date. So what are the nuts and bolts? How are you going to actually communicate the things you want to communicate? Just in one slide, I'm going to tell you sort of how you would do this. So first, choose an issue. What are the things that you really care about? Is it a specific social factor that impacts your patients? Or is it a particular disease or condition that impacts your patient population that maybe people don't know about or people aren't serving adequately? Find a community partner. Don't do this on your own. There's always this danger of physicians feeling like they have all of the answers. We have a specific skill set, but out there in the community, there are people doing the day-to-day work that understand those who have power and understand the system in a way that we might not. Along the right side of the screen, these are different community partners that we have at the Donny Pediatric Center that help us serve our patients. Find that partner to work with. Choose your audience. Is your intervention going to be patient education intervention, teaching your patients about COVID vaccine safety, for example? Or do you want to talk to medical professionals and help them understand the needs of your unique patient population so that they can better care for them? Or are you going to want to amplify the voice of your patients for decision makers, either in our hospital, in the government, in the media? And what's the message that you're going to communicate? So when I tell med students about creating a message, I say this is the same, the format for creating a message is the same if you're talking to a decision maker or if you're calling a consult. You need a hook to make them interested, an argument to tell them why, and an ask to tell them why you called them. So for example, again, for the students, I say, what if you were calling a surgeon? You might say, I think this kid, or I think this kid has a ruptured appendicitis. That's the hook. They might care about that. The argument is they have an elevated white count, a fever, and right lower quadrant tenderness. Then the request is, can you come and see him or her? So only consults were that efficient. Likewise, when you're doing an elevator spiel about a thing you care about, the hook might be, hey, I'm a pediatrician at Donny Pediatrics. Over the past few years, I've had several patients injured and who even died from death and suffocation deaths in their beds or SIDS. The argument might be safe sleep practices like sleeping on your back by yourself in a crib, decrease the likelihood of crib death by over 50%. The ask might be to a legislator, that's why I want you to support this. That's why I want you to support this piece of legislation that requires all daycares to incorporate safe sleep practices into their child care center. This was a policy that we advocated for at Advocacy Day a few years ago. So that would be the type of way that you'd start your message. And then if somebody's interested, I'm sure you'd have a lot more to say. So let me wrap this up. The last two slides are sort of putting this all together. What can you do about social determinants of health and specifically poverty? At the individual level, sort of if you remember this case, maintain an awareness about the historical geographical factors that impact your patient's health. Understand sort of the big picture that your patients bring with them. You're not going to know everything. You're going to need to ask, but at least you know the general climate that they live within. Maintain a knowledge base about resources for low-income patients. What are the things that you're going to need to know in your clinic? You don't want to, every patient can't get a social work consult, as much as I love social workers. Recognize diseases that occur with a higher prevalence in low-income patients. Kids at lower income levels, I've made the argument, are going to be sicker. What do those disease patterns look like? How will that change your differential diagnosis? Work together with patients to create achievable goals within their social constraints, saying, hey, from now on, I need you to follow up every week in clinic for your weight loss. Might just not be practical for somebody without a car. So think, how can we work together? You might not get the perfect solution, but hopefully you can get a good one. And then use motivational interview skills to encourage your patients to take the next steps. One thing Dr. Raley, if any of you know him, used to tell me, he was a former associate dean at the School of Medicine, he'd say, don't underestimate sort of the negative power of being demoralized. In other words, what he was saying is, for certain patients, the system has just failed them many, many times over. And you telling them you've got one more solution may not be very motivating. And so you're going to have to use sort of your motivational interviewing skills to say, I get it. There are a lot of challenges, but I want you to take this next step. So dust off those motivational interviewing skills. And then think broadly. What are the things that you can do to use your platform? Partner with community organizations to make your clinic better. Bring those community organizations to your clinic to think about how you can better get patients connected. Strengthen your clinic and hospital to assess and address the specific needs of your community. Our hospital does community needs assessments. Read those. What are the specific things that your community needs? Because it may be that the way that your clinic is working and what your community needs sometimes don't perfectly line up. Work with local governments, schools, and businesses to improve environmental factors and advocate for measures that impact your patient's health. If you read the AAP policy statement on medical homes, they make the argument that pediatricians should see themselves as community consultants. So the idea is go out into the community and help them understand what it is that your patients need. And then lastly, like I said, tell stories, amplify voices of your patients in their community so that the people who need to know about your patients know, so they can't say, nobody told me. All right, well, that's all I have. Any questions? Yes.
For those watching on Teams, feel free to unmute yourself and we should be able to hear your question. Is that a hand up, Keen? Oh, okay.
You don't have to have questions.
Hey, Josh, this is Kayla. Thank you for a great talk. Do you give this talk to residents?
No, just to students. Well,
Okay.
This is actually 3 talks mashed together. But yes, I only give to students right now.
Okay, well, maybe we should figure out a time for you to also share this with the residents, because this was great, and I think it's a good reminder for the work that they do. So thank you so much for sharing it with us today.
You're welcome.
There's no questions in the chat, but they do say thank you.
Oh, well, you're welcome.
Thanks again, Josh. Thanks for coming.
My pleasure. So this is recorded somewhere.
Yes.
I able to download it.
Yeah, we should be able to get that. Good.